Welcome everybody, and thank you for joining me for today's poster presentation as part of the 2021 Mental Health Research Day. My name is Alex Hofkirchner, and I'm a third-year resident in the Department of Psychiatry at Western University. Today, on behalf of our multidisciplinary research group, I'll be presenting our project entitled Clinicians' Perceptions of Team-Based Violence Risk Assessment. Before I begin, none of the authors involved in this work have any financial or other conflicts of interest to disclose. For those who might not be familiar with the term forensic mental health, we're referring to the intersection between mental health care and the law. When a person in Canada commits a criminal offense, and it's thought to be secondary to a mental disorder, he or she might be found not criminally responsible, or NCR. He or she may then be ordered to a forensic mental health facility, such as the Southwest Centre for Forensic Mental Health Care in St. Thomas, pictured here, for treatment. The Ontario Review Board is an independent tribunal that determines a person's disposition based on their level of violence risk. So for example, whether the person needs to remain detained in a facility, such as the Southwest Centre, or whether they're suitable for community living if they're felt to be at low risk of violence. The ORB determines a person's disposition at annual meetings and in part bases their decision on clinicians' reports. Violence risk assessment tools exist to help clinicians provide standardized recommendations. One such tool is the Historical Clinical Risk Management 20, version 3, or HCR 20, pictured here. It is the most widely used tool in Ontario and is validated and evidence-based. It divides risk factors into three categories: historical factors, clinical factors, and risk management factors. At the Southwest Centre, individual patient scores on the HCR 20 are reviewed every 3 months at multidisciplinary care meetings. And as you can imagine, depending on a particular clinician's practice, they may be better suited to score certain items on the HCR 20. So an occupational therapist, for example, might be able to comment on employment difficulties, whereas a social worker might be able to comment on relationship instability or lack of personal supports. The main objective behind our work was to understand how clinicians at the Southwest Centre perceive their role in violence risk assessment, as well as how they perceive a consensus-based approach to risk assessment using the HCR 20 in an inpatient forensic setting. To this end, we conducted 10 semi-structured interviews with forensic clinicians from the Southwest Centre who were trained on the HCR 20 and using it in their day-to-day practice. And this included a number of nursing staff, occupational therapists, social workers, therapeutic rec staff, one psychologist, and one psychiatrist. These interviews were conducted by my co-author Daniel, who's a medical student at Western University. After Daniel conducted interviews and these were transcribed, my other three co-authors, Courtney, Chandra, and Dr. Jason Quinn, analyzed these using inductive thematic analysis, which is a qualitative research method that looks for codes or themes within a data set without any sort of preconceived notion about what the researchers or what we were expecting to find. To increase the methodological rigor, we then used triangulation to identify common themes that came up between Chandra, Courtney, and Dr. Quinn's analysis. One of the main themes that emerged was that of utility and value. Participants generally felt that having a structured, consensus-based process for violence risk assessment was clinically useful, but also allowed them to feel that their individual contributions were being valued as part of the team. In the interest of time, I won't read these select quotations, but I'd be happy to answer questions or dial back to them during the Q&A period. Another major theme that emerged was that of facilitators or barriers to implementation, and two select barriers are identified here. The first was that of night staff potentially not having the same level of education on the HCR 20 as daytime staff. And indeed, night staff often aren't present during the daytime to share their concerns or input during the multidisciplinary care meetings. Another interesting barrier that came up was that the perceived value of risk assessment was decreased when clinicians considered the lack of resources available to address risk factors. So for example, some people felt that there weren't enough psychology groups or other groups available to actually treat modifiable risk factors that emerged. The takeaway from this work is that consensus-based violence risk assessment has been perceived as valuable, but there are continued barriers that prevent full utility. Next steps include addressing these barriers by, for example, providing education on the HCR20 for staff and addressing gaps in interdisciplinary care to address violence risk factors. Thank you very much for your time.